First of all, good afternoon, everyone, or good morning, good evening, based on where you are geographically located. I hope you all are staying safe. It is. Any problems? Yep. Okay. So it's 12:30 p.m. here in Indiana, and on behalf of my colleagues in the Education and Communications Committee.
Yeah, I did.
You. Erin, can you mute them all?
Yeah, I got it. Sorry.
Yep, thanks. So on behalf of my colleagues in the Education and Communications Committee, I'm delighted to kick off the Cancer Cachexia Society online seminar series. So the goal of these seminars is basically to continue and build upon the interactions that we started during our recent virtual meeting last September. We are hoping to host these seminars ideally on the second Wednesday of each month, usually around this time. There may be some flexibility based on the speakers' availability. We will have a break in December because of the holidays and concurrent International Cachexia Conference, as well as in summer, likely in July and in August. I invite you all again to mute yourself and to ask questions using the chat button. At the end of the talk, questions will be read by the moderator that I believe will be Erin in this case. So without further ado, I would like to introduce the first speaker of the Cancer Cachexia Seminar Series, our good friend, Dr. Michael Toth. Dr. Toth is currently a professor in the Department of Medicine at University of Vermont. He was awarded a Bachelor in Biological Sciences from the University of Vermont, followed by a PhD in Physiology from the University of Maryland. He then completed his postdoctoral training at the University of Vermont, where he's currently working as a professor and as a vice chair for research in the Department of Medicine. He has received numerous awards, and his laboratory has been constantly funded. He's currently a PI on an NIH R1, as well as a co-PI on another R1 grant. He was also awarded multiple other grants from NIH, including 2 R21s and a K1. Dr. Toth authored over 140 among research articles and reviews chapters, and he is well known in the field for being a very engaging speaker. Today, he will talk about exercise in cancer patients, cachexia, chemotherapy, and beyond. Michael, welcome, and thank you again for accepting our invitation to be the first speaker. We are looking forward for your talk.
Well, thank you, Andrea. Can everybody hear me okay?
Yeah.
Okay. So thank you, Andrea, and the Education and Communication Committee for the opportunity, but also thanks to the Society for starting this lecture series to inform the researchers and clinicians and patients about these important topics in the field. So I'd like to start by giving you a brief outline of my talk today. So I'll begin with a little bit of a background about exercise in cancer patients, and then move on to the majority of my talk will be spent about the use of exercise in cachexia. And I'd also like to speak a little bit about exercise and chemotherapy, and specifically because this is becoming, I think, an emerging area in the field. And then finish by talking a little bit more practical aspects of the use of exercise in cancer patients. So before I get into this, I'd like to just go through some definitions. And I put up here the World Health Organization definitions for physical activity and exercise. And you can see that they're quite similar. And I know that this isn't a matter of semantics. There's a lot of importance put into the language that you use to speak with patients and providers to engender enthusiasm in them for taking up activity and exercise regimens. And I don't mean to dismiss that at all. But today, I'm going to be talking mostly about exercise and as it's used in exercise intervention studies that we'll be talking about. So throughout the rest of this talk, I'll be talking and just saying exercise, but obviously not downplaying the importance of the language that we use to speak to our patients, as well as other clinicians in the field and researchers. So cachexia, as you all know, is a multi-organ syndrome. It's not only the skeletal muscle that we see in the atrophy, but it affects multiple organs and tissue systems, as you can see in here, to both have negative effects, but also to induce the wide, broad, sweeping effects of cachexia across the body. And chemotherapy, which is often given systemically, has similar broad sweeping organismal effects. And you can see here in this figure that I show just some of the chemotherapeutics that are given to breast cancer patients, the multiple different organs and tissue systems that can be impacted to have side effects from these therapies. And what I'm trying to get across here in these figures is that any preventative or remediative therapies that we're going to use in these types of patients, cachectic patients, and then more broadly, any patients that are getting chemotherapy, are going to have to be multimodal in nature to address the various effects and etiologies that occur across the body. And exercise is really, I'd say, well positioned to do that. And that's because exercise impacts a range of physiological systems that are affected by cachexia and chemotherapy. And so in this slide that I'm showing you here, this is just sort of I'd say a very narrow view of the physiological systems that are affected in an acute bout of aerobic exercise. And you can see here the cardiorespiratory systems affected, metabolism, you have the liver and the adipose tissue in order to mobilize energy substrates for the exercise, and of course the skeletal muscle. So this is sort of a tip of the iceberg kind of figure here. You can imagine there's a dramatic number of different systems that could be brought into the fold here with any exercise intervention that you're going to be doing. And one that I wanted to sort of draw attention to at the bottom of the figure here is the myokines in the skeletal muscle. These are things that are released from skeletal muscle in response to contraction or exercise that can have autocrine, paracrine, or even endocrine effects throughout the body. And that's sort of a segue into the next slide here, which shows a bunch of different myokines that were known as of the publication of this figure in 2013 and their effects on a various number of different organs and tissue systems and their signal transduction systems to affect the beneficial changes in cardiorespiratory or cardiovascular risk. And what this should give you is an idea that you can take any one of those factors in the prior figure and blow them out tremendously. And it gives you a sense of the multi-organ effects of exercise. And it's because of these broad organism-wide effects of exercise, it's really, I think, an ideal component of a multimodal regimen to improve health and outcomes in these cancer patients, and specifically to possibly address cachexia and chemotherapy effects. So when we talk about exercise along the cancer continuum, it's very important to consider exercise throughout this range, but at least for the purposes of the talk that I'm going to be giving today, it's really focusing from the time of diagnosis to the end of life. And this is a time when patients have an increased contact with caregivers, and it's a little bit easier to instill exercise in the population at that time. And in particular, this is going to be the time when we're most interested in exercise for interceding in cachexia, as well as treatment-related side effects, and in particular chemotherapy. And whether this may not be a discrete time point for some patients, but especially for those end-stage patients that were more likely to see cachexia, this is going to extend probably throughout the period of survivorship from treatment all the way to the end of life. So exercise is important throughout this continuum that we'll be talking about. So with that brief overview, I'd like to just get into the main focus of the talk today, which is going to be about exercise and its use to possibly prevent or treat cachexia. And as I guess you do with any talk when you're talking about an intervention, it's usually going to start with those preclinical studies. And exercise is a little bit unique because it's generally thought to be safe in most individuals. So we have a sort of concurrent development of exercise in both preclinical and clinical models. But I think the preclinical work is really nice in being able to do things that are very hard in patient populations, as well as discerning a little bit more on the mechanistic side of things. So we're going to start there, and I'm just going to give you a real brief overview of a few studies in the field. And so my apologies to those people whose work I'm not presenting here today. And I wanted to start with an early study in the field that looked at the effects of resistance type exercise training to attenuate muscle wasting in the C26 model of cancer. So this study looked at, and then just the exercise model that they used gives electrical stimulation to sciatic nerve. It provides for unilateral contraction of the hindland muscle, and in particular, it gets concurrent contraction of both dorsal and plantar flexors, and the plantar flexor being bigger, you get concentric contraction of plantar flexors and eccentric contraction of dorsal flexors. And they use this model starting concurrent with tumor inoculation. So in this figure that just appeared, you can see the body weights of these animals throughout the experiment. It was about a 17-week experiment. And this model that they're using, this is looking at exercise as a preventative treatment to prevent cachexia. So you can see the weight loss starting somewhere about mid-study, but the exercise is starting at the very beginning of the study. So it's kind of a unique aspect that's happens in a lot of preclinical work, and it's suggesting that exercise is being used in a more preventative fashion. I think that's kind of important, and we'll expound on that with the next study as well. But what this study showed was that resistance type exercise is effective at mitigating the muscle atrophy that these tumor-bearing animals were experiencing. You can see that in this figure where you see a drop in the unstimulated leg and the muscle size, whereas it's attenuated and actually increased slightly in the leg that receives the resistance exercise stimulus. So resistance exercise may be effective at preventing cachexia-induced muscle wasting in these animals. But in most cases, you're not probably going to be able to prevent cachexia. You're going to probably see cachexia. You're going to want to treat patients with cachexia. And this study from Jim Carson's lab addresses that. And specifically, it used the same model of eccentric induced muscle contraction to look at this in tumor-bearing animals. In this particular study, they looked at the APC-Min model of colon cancer. And they actually started their stimulation during active cachexia. So these animals were losing weight and losing muscle. And so you can see from this figure, what should be easily apparent from this figure, in all the tumor-bearing animals, you see a decrease in muscle fiber cross-sectional area. This is in the tibialis anterior. However, in both tumor and non-tumor bearing animals, the resistance exercise stimulus was sufficient to cause muscle hypertrophy. And so what this says is quite important, is that if you use exercise in a situation where you have already established cachexia, it may be effective at treating that and preventing that, and possibly even mitigating or turning back the clock and improving the muscle size. And also, I think this is important. It shows that this is also happening in the types of muscle fibers that, for example, in this one on the bottom of the figure, the MHC, or the myosin heavy chain 2A, a fast twitch type muscle fiber that is very prevalent in human muscle. So these effects may be translatable to human patients. So I wanted to also speak not only to resistance exercise, but talk a little bit about aerobic exercise. This is a study looking again in the C26 model of cancer at the effects of aerobic exercise. This study was a 19-day study, and they had the animals, they allowed the animals with or without free access to a running wheel, which was their exercise stimulus. And this also looked at some pharmacological treatments, which I won't be talking about today, but you can see the animals with the tumor-bearing animals were losing weight over this 19-day study period, whereas the animals that received the wheel running, or the running wheel in their cage and exercised, the exercise was sufficient to prevent this weight loss that occurred. And then they went on in the study nicely to show that in those tumor-bearing animals, this prevention of weight loss was associated with greater amounts of muscle weight and also muscle cross-sectional area at the cellular level. So this suggests that aerobic exercise may be effective at preventing both the weight loss and the muscle atrophy that occurs in cancer cachexia. And I just wanted to briefly talk a little bit about the exercise that these animals are undergoing. So I know in preclinical work, you can talk a lot about how this translates and how relevant this is to humans. And I'm not going to really get into that too much, but I did want to highlight some aspects of the exercise that these animals undertook. So the tumor-bearing animals exercised on average of about a little bit over 40 minutes per day. And they exercised at a speed that was about 30 meters per minute on the wheel. And so why I do this is it segues into the next study I wanted to present, which is a study that was just published last year that looked at the preventative effects of low intensity exercise on cancer cachexia-induced muscle wasting. And this study, I'm not going to go into the details of the design, but what I wanted to highlight here was this study looked at exercise that was about 30 minutes per day, so slightly less than the prior study, and only about 15 meters per minute, so about half the speed of the prior study. So you could, again, we can argue about how this relates to humans, but compared to the prior study, it's a much lower intensity exercise. And this table shows much of the results from this study. And the ones I want to key in for you here is that unlike the prior study, this low intensity exercise was not effective at preventing body weight loss in these animals. So they still experienced body weight loss associated with cancer. However, it was effective at preventing muscle atrophy. So this is, again, it's very, very encouraging that exercise may have these beneficial effects. And just to summarize what I talked to you, or what I'm presenting about the preclinical evidence in this field, is that it appears that there's effects of both resistance and aerobic exercise to preserve skeletal muscle size and possibly body weight. Again, there's a lot of questions about how these preclinical models translate to humans, both in the timing of the exercise, because most of the cases it's used in a preventative fashion, as well as how the dose translates. But the last study I showed you is encouraging because it suggests that low intensity exercise may have benefits to maintain skeletal muscle as well. So a lot of the preclinical work has been encouraging in suggesting that exercise may mitigate cachexia, and in particular by maintaining muscle size. So really what we want to know as far as translating this is, what do the clinical studies say, and what is the evidence from randomized controlled trials? So I'll say ahead of time is that there's just not a lot of studies in this field. So what I decided to do was to just select a number of studies across this continuum of cancer care continuum. And I focused those studies on those particular cancers that have high incidences of cachexia. And the reason for this is there's actually not a lot of studies that have focused specifically on cachectic populations and selected for them in their inclusion criteria. And because of that, we're a little limited in what we can say about how exercise is affecting cachexia. So I'll go through a few studies. The first one is looking at how aerobic exercise pre-surgery in patients with lung cancer might benefit. And so we're talking about right after diagnosis, before treatment. And the whole premise for this study was that surgery in these patients has a tremendously deconditioning effect, and it might be helpful for exercise pre-surgery to help provide sort of a prehabilitation for these patients, to provide them with greater physiological reserve prior to their surgery. So just going to give a brief outline of each study like this. This is a single-arm pilot study in non-small cell lung carcinomas. They were approached right after diagnosis, and they went into, if they agreed, a 5-time per week exercise training study. And so they did it right up to surgery. So on average, there were 30 sessions completed. So it's about a 6-week training study. It was generally low intensity in the 60 to 65% peak VO2 training level. But they did do some brief high intensity exercise at the end of each session. So this is, as you can see, this is an early study, 2007, relatively early, about 13 years ago, but it was an early adopter of a high intensity interval type training approach. And this table shows the majority of results from the study that I'd like to talk about. And the one that I'd first like to start with is that this study found an increase in peak VO2 of about 11%. So to put that into context, what you see with a standard clinical rehabilitation, exercise rehabilitation approach, like a cardiac rehab program or something, is about a 10 to 15% improvement. So, and that's over a much longer period of time. So this is actually right in the ballpark of what you'd expect. And not only do we see an increase in physiological capacity for aerobic exercise, but we also see an increase in 6-minute walk performance. So this is actually a 6-minute walk. This should be meters, not minutes. It's incorrectly labeled. they saw about a 40-meter improvement in walking performance in these patients. And that's important because a minimal clinically important difference in this outcome is usually somewhere around 30 meters. So this is an important improvement. So exercise not only improves physiological capacity, but also improves the ability of these patients to perform an important and essential activity of daily life. So moving along here, I wanted to look at another study that used resistance exercise training, and in this case to rebuild lean body mass in patients with head and neck cancer. And so a little bit of background, in this population, they see, there's prior studies that had shown that they see about a 4 to 5% decrease in lean body mass during radiation therapy. And so this study wanted to see is after radiation therapy, could resistance exercise help rebuild muscle mass in these patients? And so this was a randomized crossover design style study where it was done at multiple sites, and patients were randomized to 12 weeks of either self-selected exercise or progressive resistance exercise in a crossover fashion. So as you can see here, they either received first for 12 weeks after radiation, they received progressive resistance training and a facility-based progressive resistance training, followed by 12 weeks of self-chosen activity, or vice versa. So just to show you the results from this, I wanted to orient you. There's a lot going on this slide. So everything here is expressed as a change, and any asterisks you see suggests a significant change from baseline. And then any pound symbol would suggest a change different from the corresponding time difference. So looking at the first one, it's early progressive resistance against early self-chosen activity. And the thing that I want to really highlight with this study is how effective resistance exercise was at improving lean body mass in these patients. So remember, I told you it was about a 4 to 5% drop in lean body mass during radiation therapy in these patients. And the resistance exercise they did was able to increase their lean body mass by 4%. So you're seeing a nice effect of resistance exercise to basically rebuild muscle in these patients. And in fact, over the entire 24-week period that all these patients were studied, the lean body mass went up about 4.5 to 6%. So pretty much remediating all of the lean body mass loss expected during radiation therapy. But it wasn't only an increase in lean body mass, these patients were also becoming stronger. There were multiple measurements of lower extremity and upper extremity strength that improved, as well as physical performance, seeing an increase in chair rise performance in these patients. So not only an improvement in or a restitution of muscle size in these patients, was presumably because of the increase in lean body mass, but also an improvement in muscle function as well. And the next study again is looking at resistance exercise training. And this is in a pancreatic cancer population. And this is looking at its impact on physical fitness, physical function, and body weight over time. And so along that cancer care continuum, these patients were started in this exercise program about 100 days post-surgery or 60 days post-chemo. I should point out that these pancreatic cancer patients, they were about 50% of them were cachectic. And the randomization distributed cachectic patients about evenly throughout the intervention period in the different groups. And it was a randomized controlled trial with 3 arms. There was patients were randomized to facility-based resistance training, home-based, or no usual care control. And this was a long study. It was done for 6 months. And this table highlights a lot of the strength measurements that were done. And the one that I wanted to kind of draw your attention to was the knee extensor strengths. These are important muscles for common everyday activities of daily living. And you can see that the facility-based resistance exercise training, the RT1 group here, had an increase in their knee extensor strength, as did the home-based resistance exercise training. So the resistance exercise is increasing muscle strength as we might expect it to. However, it didn't increase aerobic fitness in these patients or 6-minute walk performance, and it didn't have any effects to differentially affect body weight between the groups. But an important point about that is that there weren't significant changes in body weight across with time across any of the intervention groups or controls. So it's a little bit questionable what this is really telling us, because we're not seeing a substantial amount of weight loss in these patients. But I just wanted to follow up that study with another study that was almost a carbon copy of the last one, with the exception of the fact that it specifically looked at pancreatic cancer patients who were cachectic. So in the inclusion criteria in the study, they only chose cachectic patients based on the standard definition for cachexia that we all know. And this study was literally just recently published and is available online in preprint. And as I said, it's very similar to the last study. They started the exercise about 100 days post-surgery and about 50 days post-chemo. And their primary outcomes were lean body mass and muscle function. It was a randomized controlled trial of supervised facility-based resistance exercise. So they start in the first month at a low to moderate intensity and move up to the remainder of the study at a more moderate to high intensity. And they were doing this for 2 days per week for 12 weeks. So a little bit shorter than the last study. Well, what you can see here from this table, the results on the lean body mass, and across all the different metrics that we have for looking at appendicular lean body mass, which is basically skeletal muscle mass, what you can see is that the resistance exercise was able to actually increase lean body mass in the arms and legs by about 0.5 kilogram compared to the control group, which is pretty substantial over the context of the 12-week time period that we have in the study. Unfortunately, the study didn't look at body weight changes. It didn't report that, so I can't tell you how much weight they lost and if the resistance exercise helped to prevent it, but I would imagine at least to some extent it did, considering it mitigated some of the lean body mass changes. And then not only did it mitigate the lean body mass loss, but it also improved function. So over most of the functional outcomes, the walking tests, as well as the chair rise stand, we saw improvements in the resistance exercise training group. And I should point out that the improvements here are actually a decrease in these numbers in this group, because this is the time it takes, for example, to walk 400 meters, and a decrease in that is actually an improvement. So a little bit odd, but it did improve function across all of these different metrics. So just a sampling of studies that have been done in this field. The one thing that you should get across from this is there are very few randomized controlled trials that have been done specifically in cachectic populations. There's been a fair amount that have been done in late stage cancer patients. However, in a lot of those populations, even though they have high rates of cachexia, they haven't really classified patients for cachexia, or they haven't selectively recruited those patients for cachexia. So our ability to really come to conclusions about how effective exercise is at mitigating cachexia is somewhat limited at this time. Similarly, few studies have really done measurements of muscle mass, and some don't even report measures such as changes in body weight or fat mass over time. So it's very difficult to tell how effective exercise may be at mitigating the body compositional changes that you expect in cachectic populations. However, the one positive thing, I told you a lot about limitations, is that exercise generally improves physical function, and it does it in a modality-specific fashion. And I think there was a really nice review article that was published a couple of years ago that looked at exercise in a variety of incurable cancer populations. And what they showed was that there was about a 10% improvement in VO2 max, about a 7% improvement in 6-minute walk time, and just north of 30% improvement in 1 repetition leg strength. And these are all, like I said, about modality specific, and there's about 6 or 8 studies contributing to these averages in each one. So there's been a fair amount of work to suggest that exercise is probably good at improving physical function, as we might expect. But at this point in time, even though it may have such benefits, there's too little data to draw definitive conclusions regarding its effects to mitigate cachexia. So I also wanted to speak a little bit about chemotherapy. If anybody's been to the cancer cachexia meetings, the last one, or more specifically over the last few meetings, what you'll notice is that you're seeing a lot more presentations about chemotherapy and what effects it might have on muscle in particular. And I wanted to talk about this because in most cases, in all the patient populations you're going to be looking at, they're going to be treated, and most often with chemotherapy. So it's always going to have some kind of effect in addition to the cachexia that you may be seeing in patients. And the reason that there's maybe not as much work done in this field as there is in the cancer cachexia field is that there's a range of drugs and regimens that can be used for any cancer, it's often in combination with other supportive therapies and targeted and now immunotherapies. And so it's really difficult to assess the effects of any one chemotherapeutic agent and how it might be working. And just again, just to highlight that figure I showed you at the beginning, the range of medications that can be used in just a breast cancer population, for example, which is the one I'll be presenting some clinical data on in a few slides. But as with the cachexia part of the talk, I wanted to start by talking about some preclinical work. And this is a really nice study that was done looking at the effects of cisplatin-induced muscle wasting in mice. And so they don't have a figure on the study design, so I apologize, but I'll just briefly give you an overview. It was a 6-week study, and they gave weekly doses of cisplatin, which I think is kind of important to underscore because you really want to look at the cumulative effects and not a single dose of chemotherapy, because in patients, that's typically what you're seeing is side effects that occur over a cumulative nature, as well as things like muscle side effects and muscle atrophy. So it was nice in doing sort of this repeated dose kind of approach. And they allowed the animals to have free access to running wheels. Some did, but some did not. And that was their exercise stimulus. And so just to show you some data on this study, the weekly cisplatin dose caused body weight loss in these animals. And that was slightly attenuated with exercise, but you can see that these animals were still did not achieve body weights that were comparable to either of the control groups. And the prevention, the attenuation of weight loss in these animals that were exercising that were given cisplatin was due to a stimulation of food intake. So the orexigenic effects of exercise are well known. And that's likely the reason for the attenuation of weight loss in these animals. But I'd point out that even though you do get increase in food intake back up to control levels, it wasn't up to control plus exercise. And the exercise itself is going to have an energetic burden on these patients. On these mice. So you're probably getting a failure to increase intake all the way up to the energy expenditure that they're doing, and that's added on by the exercise. And that's an important point I'll expound on a little bit. But like the body weight changes, we saw with if you look at lean body mass, there was a decrease in the cisplatin-treated animals, but that was mitigated by exercise. It wasn't back up to the levels of the normal control group or the exercise control group, but it was largely mitigating most of the weight loss that these animals saw. And that was, lean body mass loss. And this was due to diminution of the muscle atrophy that these animals had. Again, not back up to control levels, but it still did diminish the atrophy that was apparent in the cisplatin treated without exercise. And not only did it decrease the atrophy, but it also improved the functionality of the muscle, as shown here. The cisplatin treated plus exercise group was comparable to all the control animals in their performance in a hang test. So exercise is effective at both mitigating some weight loss, muscle atrophy, and muscle dysfunction that occurs with chemotherapy. So that's a preclinical study, and I also wanted to show some information and some data from a really nice clinical study that was published a couple of years ago that looked at the effects of exercise training during chemotherapy in breast cancer patients. And this focuses mostly on skeletal muscle measurements from muscle biopsies. And looking across the cancer continuum, these patients were studied after surgery. So all of these patients received resection of their tumor. So in this particular study, we'd assume that all the effects that we're seeing over time in these patients are not due to any tumor-related effects because they've had their tumor removed. And then they received chemotherapy. And importantly, all of these patients received anthracycline type chemotherapy that has well-known cardiomyopathic and some just more generalized striated myopathic effects. So you'd expect this population specifically to have effects on skeletal muscle. And this was a randomized controlled trial of supervised facility-based aerobic and resistance training that was combined with brief at the end of each training session, high intensity interval training for 16 weeks. So the first thing I wanted to highlight in the data from this study was, I think, a very important point, which was there are changes in muscle fiber size that occurs in these patients over the 16 weeks. So there was a observation of reductions of 25 to a little bit north of 30% in muscle fiber size during the 16-week study period. So I think this underscores my point that I brought up, why I'm talking about this in the first place, is this is a profound effect to cause muscle atrophy in these patients. So you can imagine if this is occurring in a cachectic population, it's just going to make any of the cachexia that's happening in that patient that much worse. And to see it in a population such as breast cancer patients who generally have very low levels of low incidence of cachexia is pretty pronounced. But on the positive side, the study found that both aerobic and resistance training was effective at mitigating this decrease in muscle fiber size. And in fact, in the resistance training group, you can see that there's an increase in muscle fiber size over the 16 weeks. So very positive effects of exercise to mitigate chemotherapy-related atrophy. The study also looked at mitochondrial enzyme activity, citrate synthase activity, an important enzyme in mitochondrial oxidative metabolism. And again, you can see just over the 16-week observation period in the control group, you see a pronounced drop in citrate synthase activity, whereas in both the aerobic and resistance training groups, you can see that the citrate synthase activity is maintained. So these are all measurements on pieces of muscle tissue from biopsy. So what does this mean sort of functionally? This research group took all the functional data on these patients and they presented that in a follow-up paper. And what you can see here is in the control patients, you see a pronounced drop in aerobic fitness during the 16 weeks, and that is prevented in both the resistance and aerobic train group. And then you also see a non-significant but slight drop in thigh muscle strength in the control group, which is completely mitigated. And in fact, there's increases in muscle strength in both the aerobic and the resistance train group. So not only can aerobic and resistance training in this study prevent muscle atrophy, but it also has these beneficial effects to improve function in these patients. So just a little overview of what I've talked about on the chemotherapy side of things. Chemotherapy, I think importantly, may potentiate body weight loss and muscle atrophy in cancer patients generally. And so that may be outside of our classical cachectic populations, but also to worsen cachexia in those cancer populations who are suffering from cachexia and receiving chemotherapy. And the preclinical and clinical data suggests that exercise may mitigate these negative effects of chemotherapy on muscle size and function. But there have been very few, just like the cachexia field, there's been very few randomized controlled trials that have looked at exercise and its effects on muscle size and function in the setting of chemotherapy. So while chemotherapy may compound cachexia and have these detrimental effects on muscle, right now is very little known about whether or not exercise is going to be effective at mitigating these in patients, unfortunately. So I've talked to you a lot about what we don't know, and I think that's just unfortunate because it's a function of what is available in the literature right now. I think we're sort of working to a point where exercise is becoming a more accepted therapy in cancer patients, and I think this will change over time. But I wanted to provide a little bit of discussion about how we might be able to use exercise in cancer survivors, and in particular in cachectic patients. So any kind of discussion like this has to start with what we know and what guidelines are out there. And so I just wanted to give you a little bit of a background on what guidelines have been published and what they say. So This is the first report of a roundtable from the American College of Sports Medicine looking at exercise guidelines for cancer survivors. And this was published in 2010. And at the time, there hadn't been a lot of randomized controlled trials of exercise in cancer patients. So but there was enough that they had sufficient evidence to say that exercise improves physical fitness, function, quality of life, and fatigue. But at that particular time, they couldn't offer specific exercise prescriptions to do this. And so they fell back on the prescription that was given to basically healthy controls, which was 150 minutes per week of aerobic activity or 2 or more days of resistance exercise. Fast forward 10 years, we've had a tremendous increase in the number of studies, randomized controlled trial studies that have looked at exercise in cancer survivors. And the ACSM Roundtable published another report just last year, and it provides a lot more guidance regarding the evidence, strong and moderate, suggesting that exercise has effects on various different side effects and symptoms of cancer. But I think one thing that should stand out from this, it's conspicuously missing, is cachexia. And I think it's offered an explanation of why that is in the latest ASCO guidelines for the management of cancer cachexia that were published in 2020. And you can see there in their third recommendation that unfortunately at this point in time, there is insufficient data to offer any guidelines for other interventions such as exercise. And basically, as I said before, the lack of randomized controlled trial evidence doesn't provide us with enough data to make recommendations at this point in time. However, I know that there's going to be some clinicians and some patients that want to undergo exercise, and I think we have to start thinking about how we can maybe integrate this into cancer care. So I wanted to just basically give some maybe cautionary notes as we start to think about moving forward about using exercise in patients and what we might want to think about. But it also provides a little bit of a backdrop and something to think about for the basic scientists working in preclinical models as well. And the first one is going to be the understanding that cachexia is caused by negative energy imbalance. And that's provided in this figure down here, this little seesaw figure that shows the balance between energy intake and energy expenditure. And you can see the energy expenditure components there: resting energy expenditure, physical activity energy expenditure, and then thermic effective meal. And so this negative energy imbalance is often shown as a tipping of the seesaw, where the energy intake goes down and the total energy expenditure goes up. But I think, and it's often even said that that's the case, that there's an increased energy requirements in these cancer patients. And I think that that's a bit of a misnomer, and I wanted to show you a little bit of data to back that up. So this is a study that was published a few years back. It's a dietary intervention trial, but it measured total energy expenditure in cachectic pancreatic cancer population. And what you can see here is some data on measurements of energy expenditure and its components compared to age, sex, and body size predicted norms. And so the first thing you can see here is that resting energy expenditure is increased in these patients. And that's been shown before, and it's what you might expect. So they're hypermetabolic. They have a resting hypermetabolism. However, when you look across at their total energy expenditure, they're actually burning less calories than you might expect for their age, sex, and body size. And the reason for that is when you look at their activity energy expenditure, they have pronounced reductions in activity energy expenditure. And again, not something surprising. As people get sick, they get less active. And this follows with a lot of data that was gathered in the late 80s and throughout the 90s, both longitudinal, cross-sectional, and disease populations, where total energy expenditure was measured with doubly leveled water. And you can see that even though a lot of diseases have resting hypermetabolism, in general, they have dramatic drops in physical activity energy expenditure, and the net effect of this is a reduction in daily energy expenditure. So even though it's often shown in this way, what you can kind of think of cachexia as being is a reduction in daily energy requirements or energy expenditure in these patients, but a much more pronounced reduction in energy intake. And that offers an opportunity for exercise because, as I showed in the one preclinical study I showed you, exercise has a potent effect to induce energy intake. Now, whether or not this is the case in cancer patients is not clear yet. And I think it comes with a sort of caveat, which is depending on the type of exercise that you use, it might in and of itself exert an energetic burden, which may actually could make weight loss worse. And that's one of the reasons why in a lot of cachectic populations, you see them using resistance exercise because it has a less energetic burden than, say, an aerobic exercise intervention. And it's definitely something that we need to consider when we think about what types of exercise programs we want to use in patients, but also the extent of the energetic burden of those interventions and how that may impact further cachexia or resolution thereof. Another issue I want to bring up, which I think is important to consider, is that patients' motivation towards exercise. And this is a study that was published a couple of years ago that looked at this in patients with the cancer cachectic patients. And what they found was that these patients generally had low levels of exercise, low history of performance in exercise, and generally a low self-efficacy towards exercise. And they asked them about their preferences for exercise. Most said that they wanted to do low intensity home-based exercise. And I think these kind of consideration of these preferences is very important, as well as these patients' predisposition towards exercise. And I wanted to follow up that with a study, a nice study that was published in 2011 that looked at what patient preferences were in incurable cancer populations. And this study asked patients if they would be interested and willing to participate in an exercise study. And I think pretty promisingly, they showed about 2/3 of patients agreed that they would be willing or interested in participating in exercise. And then they also asked them what kind of exercise they would prefer. And the types that they preferred were things like neuromuscular stimulation, walking, and resistance exercise. And again, they were interested in a format that was more home-based and unsupervised. And so I think what we need is a lot of more studies that are facility-based to show the efficacy or lack thereof of exercise in treating cachexia. But when we think about having to implement this in a patient population, we're going to have to do this outside of those more classical type of exercise intervention and exercise dissemination approaches. It's going to have to be looking something different than what we're used to in our classical exercise training studies in otherwise healthy people. And I wanted to take a little bit of time to highlight one of these, which is called neuromuscular stimulation. So what this is using a small handheld device that with electrodes placed over a muscle can induce muscle contraction. And you can do this in ways that can cause either an aerobic type muscle conditioning or resistance type muscle conditioning. And based somewhat on this study, we wanted to see whether or not this would be effective in cancer patients, and specifically in breast cancer patients receiving chemotherapy. And we published this study. This is a randomized controlled trial just this last year. And what I want you to focus on here is the changes that we saw. This is an 8-week trial in breast cancer patients. And what we saw was an increase in skeletal muscle fiber size in these patients over 8 weeks with the use of the neuromuscular stim. And this was due mostly to an increase in their fast twitch, the myosin heavy chain 2A fibers, which are more responsive to resistance type training, which is what we try to emulate with this program, which suggests that this treatment, although I'm not obviously advocating this outside of regular exercise, that would be more ideal for any patient. But in the absence of their ability to do that or willingness to do that, these types of interventions might be effective at giving them the benefits of exercise, in particular, improving muscle size. And then I also wanted to show you that there was a systematic and review and meta-analysis about the use of neuromuscular stim in cancer patients. And there's very few papers out there. But what they did find was that in self-reported quality of life measures of function, that these patients were actually improving with neuromuscular stim, suggesting that it may have some real world effects to improve function in these folks as well. And then the last point I wanted to talk about is the safety, which I think is probably the paramount first thing we want to think about in these populations. And exercise is generally safe. And most of the studies and the consensus reports out there would say this, as long as appropriate accommodations are made for contraindications in clinical conditions, such as fatigue, things like bone metastases. There have been several studies that have done resistance exercise in these groups effectively. Frailty, especially our older populations, about maybe considering that they may be at risk for greater injury or for example, like fall risk in walking or treadmill-based exercise training programs. Anemia, again, could be limiting for if you're going to try to put somebody into an aerobic type training regimen, and anybody neutropenic, obviously we don't want in any kind of group-based exercise training program if at that time when they're at an increased susceptibility for infection. And then also cardiomyopathy, especially with some of the chemotherapeutics that we're using, like the anthracyclines, or general cardiovascular disease risk in these populations. These are all important considerations, and I don't mean to downplay them, but even the ACSM recent guidelines suggested that low-intensity aerobic exercise or progressive resistance exercise programs, which have at least shown some benefit in animal models, really do not require a pre-programmed medical evaluation or direct oversight in most patients. And again, this is relative to clinical judgment, but they're trying to remove some of the some of the barriers to exercise implementation in these groups. And these types of programs are probably safe in most populations. So just a review of everything that I've talked about today. There's very few randomized controlled trials that have been conducted, and few have evaluated those important outcomes for cachexia. But exercise generally improves physical function, and it may also work to improve muscle maladaptations that occur with chemotherapy. So exercise at this point in time, we can say can improve function and probably quality of life, but its ability to counter cachexia or the effects of chemotherapy, I think at this time are inconclusive. So part of my title was And Beyond. So I'd like to finish today by just talking about some of the questions I think that are going to be important for the future and the research that comes in the next few years. And the first one is, I think, the fundamental question: is exercise effective at countering cachexia and the detrimental effects of chemotherapy in patients? And I think it's important to ask that question more broadly in something like a randomized controlled trial, but also in preclinical models as well, to understand the mechanisms whereby exercise might be working. And the reason for this is we need to understand how different exercise regimens and muscle contraction modulate the effects of cachexia or chemotherapy on skeletal muscle. And the reason for that is understanding a little bit more fundamentally how exercise is working can allow you to better identify and inform what dose of exercise and what type of exercise you want to use that has the greatest benefit on the patients, importantly with the least burden. Again, taking in mind what their preferences are and what they're capable of doing. And then lastly, developing exercise modalities and programs that address patient needs and preferences to make sure we improve the uptake and adherence to exercise in these populations. And with that, I would like to conclude my talk and thank everybody for their attention.
Thanks so much, Dr. Toth, for a really wonderful overview. For those of you who don't know the field very well, this is a really challenging task that we gave Michael, and so we're really grateful for all the effort you put into this. If you have questions, please put them in the chat and I will read them and allow Michael to answer them. And first, I just wanted to say thanks to all 75 of you who joined us. It's really awesome to see such interest in this topic. So Matt Maddox says, thanks for an excellent talk and including some very recent data. I'm interested in why so many clinical studies in groups with or at high risk of negative energy balance intervene with exercise without concurrent provision of nutrition. So he says, a naive question, how do the preclinical cachexia studies account for the energy cost of exercise?
Yeah, so I can, to the first question, I don't know why. I think you would want to regardless. I haven't conducted a lot of those studies in the high-risk cachectic population, so I can't answer that to you, and maybe someone else can speak to that, unfortunately, maybe not in this forum. As to the preclinical ones, I know they have free access to food in most of these instances, and even in these animals, there tends to be, there's a well-trodden, there's a lot of evidence showing that exercise, even in tumor-bearing animals, stimulates intake. And so I think these animals are just eating more in response to the exercise, to answer your question. But I think in patient populations, we're going to have to make a concerted effort to actually make sure they're supplementing their intake to assure that they don't go into more further energy deficit.
You touched on this a little bit, but the question is, could exercise and poor nutrition advice or the lack of nutritional counseling actually lead to detrimental effects in some patients? And is it something that we, and people who design clinical trials and prescribe exercise for their patients need to be careful of?
Absolutely. And I think it's also even on the, not only on the energy balance side of things, but also on the resistance exercise. I didn't have time to put this in, but there was some really nice studies from Dennis Guttridge's lab about the frailty of the muscle membrane in cancer cachexia, and that's actually been followed up by some nice studies from Andy Judge's work lab to show that in pancreatic cancer patients. So resistance exercise may damage the muscle, and you may get into this sort of futile cycle where you're damaging the muscle and you can't actually you can't remediate that damage and grow the muscle. Now, the pancreatic cancer study that I did show actually suggests that it seemed to work quite well. But there may be patients where exercise may be too damaging, like resistance type exercise may be too damaging, and they may not adapt. And there's some data in older adults that that's the case. So I think, yeah, you have to be very careful. And that's why I said, I think starting with a low intensity type program is the way to go, both with aerobic exercise from the extent of the energetic burden, but also in the resistance as far as the load.
Great. The recruitment rate for randomized controlled trials that include exercise for cancer cachexia is often very low, between 10 to 20%. Do you have any ideas how clinical investigators can be more inclusive in their recruitment and try to help people participate more?
Yeah, I don't, but if anybody has any good ideas, please email me. It's a struggle. It's one of the hardest populations I've ever worked in, and I've worked in a lot of different disease populations over the years. I think that we have to start meeting the patients where they want to be, and that's one of the reasons why we went into testing neuromuscular electrical stim. I think what we have to start doing is starting to trying to move these interventions more towards a home-based type approach, and I know that reduces the ability of us to really have the strict kind of experimental control we want over this. But I think that that's kind of the way we're going to have to go, because I just think in the absence of a wide-scale oncology rehabilitation infrastructure, I don't think we're going to be able to get these patients to come in and do this. I think hopefully that's where everybody wants to get, but we're not there yet. And I think we have to meet the patients where they want to be, which is more home-based at this point in time.
Yeah, I'll summarize a couple of questions together and say that in those home-based exercise programs, there's a lot of questions about compliance and concerns about patients adhering to the regimen that you've suggested for them. Did you specifically in your study work to address adherence or compliance? And do you have any advice for people in doing that?
We did not, other than that we could look at compliance because the devices themselves have a covert monitoring option in the software, so we could tell exactly how much they did and didn't rely on them telling us how much they did. I would say that there's a lot of options. We have tried to actually take those devices and jury rig them to make them so that we can use them with a cell phone app to actually in real time monitor what they're doing. But there are so many wearable sensors right now to allow you to really assess on a minute-to-minute basis how active people are. I think that this aspect is just a matter of advancing the technology to monitor at home how these patients are doing their exercise and if they're doing it. I think it's within our grasp, and I think we're getting there. And I just would urge people to try those approaches to improve your oversight of patients outside of the clinic or the exercise facility.
Another question, there are suggestions that losing fat mass is associated with poor outcomes in cachectic patients. So do you have ideas for ways to optimize exercise regimens to promote muscle growth and maintaining muscle and maintaining weight, but limiting fat loss?
Yeah, and aside of making sure that the energetic burden isn't excessive, that you're causing a greater negative energy balance, I don't really have any good answers to that question, unfortunately. I know that most of the interventions that we have on a pharmacological side and many of the nutritional interventions tend to add body fat without adding muscle. So like, again, if we have a multimodal intervention, including exercise, plus some of these other interventions that have been shown to increase body weight, but mostly because of increasing body fat, you may get a situation where you can improve both. But right now, from an exercise standpoint, I don't know that anybody would ever say that exercise is going to be effective at increasing body fat. So I think it's going to have to go with a multimodal intervention to address the adipose tissue depletion.
Yeah, I think that's a really great answer and a holistic way of thinking about things. Is there any evidence that something like an exercise mimetic or a mitochondrial targeted compound might be able to improve muscle mass or muscle function to kind of get around some of those exercise compliance issues and the challenges of getting patients to participate?
Yeah, so there is some data in, and there's the one study I showed that did use some pharmacological agents. There have been some evidence that suggests that there are some agents that might benefit and prevent cachexia. I haven't seen too many that show beneficial effects like anabolic effects aside of that, or effects to mimic aerobic exercise and the benefits that you're getting. In most cases, they're more preventative, if anything. I would urge caution, and there's data also to suggest, there's really good data to show that, in a number of different animal models that suggest that, mitochondrial targeted antioxidants might be effective at mitigating the effects of chemotherapeutics, especially those that have mitotoxicity. However, I would say, just working with clinicians a lot over the last about 8-9 years in this field, is that most clinicians won't allow me to give anything to their patients. And if I say anything like that, their first question to me is you're not giving anything to them, right? Because we found over time, there's data out there now showing that antioxidants may have detrimental effects, not only on the therapies that are given to these patients, but just more generally to increase metastases. So I kind of tend to move away from the exercise mimetics, because at least all the clinicians I work with, they don't want to see their patients taking anything like that, because of its possibility for exacerbating their primary cancer.
I think that's an experience that all of us have had, particularly concerns about additional toxicity and increasing the burden on these patients. So we are at the hour. So I first wanted to remind everyone that if you're interested in more information about the Cancer Cachexia Society, if you saw us on Twitter, you can DM anybody who tweeted about it, and we can provide more information. Or there is an email at the bottom of your email that you received announcing the talk that also can provide more information. And thank you, Michael, for a really wonderful talk.